So good morning, all people present in the room and remotely. Welcoming people from Beth Israel, if you guys, are they connected now? And to our upstate residency program, and people who I see from the social work department and preventive medicine, public health. Welcome everybody. It's an unbelievable honor today to host Dr. Mary Travis Bassett, who's the Commissioner of Health of the New York City Department of Health and Mental Hygiene. Dr. Bassett is truly a rock star in public health. She's not only been working in public health for more than 30 years, but she has been focusing her work on health equity, which, as you know, is one of the topics that those of us at the Institute hold dear to our hearts. Dr. Bassett's a native of New York City, and except for her time at Harvard when she got her BA in history and science, her medical training was right here in New York. She got an MD from Columbia and completed her medical residency at the Harlem Hospital Center. Her MPH was earned at the University of Washington. She served for many years as associate editor of the American Journal of Public Health. After Dr. Bassett completed her medical training, she moved to Zimbabwe. I hope we'll hear a little bit about that, where she served on the medical faculty at the University of Zimbabwe for 17 years. In that role, she developed a range of AIDS prevention interventions to address one of the world's worst AIDS epidemics. She later served as the Associate Director of Health Equity at the Rockefeller Foundation's Southern African Office, overseeing its AIDS Africa portfolio. In 2002, Dr. Bassett was appointed Deputy Commissioner of Health, Promotion and Disease Prevention at the New York City Department of Health and Mental Hygiene, where she directed some major groundbreaking initiatives, including some of our favorites, the ban on smoking and trans fats in restaurants, and the requirement at chain restaurants to post calorie counts. She also established the department district public health offices in East and Central Harlem, the South Bronx, and North and Central Brooklyn to lead targeted health and communication strategies in these communities that experience the biggest excess burden of disease in New York City. And as many of you know, our own relationship with the Bronx District Public Health Office has been an incredible one, and we've been working with them for years on our work through the Bronx Health Reach program, working with nutrition and exercise programs and diabetes initiatives. These district offices advance community health through home visiting programs, free exercise programs, and efforts to increase access to healthy food. They also meet with area doctors. These are the good reps that come to doctors' offices and coordinate with local coalitions. Since 2009, Dr. Bassett served at the Doris Duke Charitable Foundation as Program Director for African Health Initiative, and more recently has led the Child Wellbeing Program. Both portfolios are focused on strengthening systems to support health improvement. So it should be very clear to you all why Mayor Bill de Blasio, who we're looking forward to is making major changes in New York City, would pick Dr. Bassett for this very important job, one that impacts both our professional work and also protects us personally while we are at work and live in New York City. I, for one, look forward to working with Dr. Bassett, who shares our passion for health equity and fighting health disparities, and really shares the values of our institute and the Department of Family Medicine and Community Health at Sinai. It's my distinct pleasure to introduce Dr. Bassett. I think is this your first trip to Mount Sinai in your official capacity?
I've met your president.
Right, and basically made us wait 3 months because we actually invited her to do grand rounds, I think the day after she was inducted as health commissioner. So thank you very much for joining us.
Thank you, Neil, for that very kind introduction. It's a real pleasure to be here this morning. I'm going to talk about one of my key priorities as commissioner, the title of my talk, Neighborhood Disparities and Place-Based Solutions. But I think we'll have some time for question and answers at the end. So feel free. I do want to say that the notion of focusing on health districts is one that came out of my international work and was a prime part of Zimbabwe's initial enormous success in bringing health improvements to its population. Of course, it also has a long history in New York City, the notion of health districts. The mayor, Bill de Blasio, who I'm honored appointed me as health commissioner, really has elevated the issue of escalating income inequality and all of its ramifications in our city into a citywide and even national discussion. So we are able to talk about the fact that although this is one of the richest cities in the world, half of the population lives at or near poverty. So I know that I'm speaking to an audience of the converted, of the most public health oriented, of the clinical community, but I think we should all appreciate how important it is that we are beginning to talk about these issues at the highest levels of government in our city. And I also want to say what an enormous thrill it was for us at the department to see 51,000 children enter pre-K on the first day of school last week. So let me begin by first outlining what all of you know, the enormous variations in health across our population, which also, because we're a highly segregated city, by some measures, New York City is the third most segregated city in the country. If you look, for example, at the black-white dissimilarity index. We can also talk about these differences by population as differences by neighborhoods. I'm going to outline some of the things that we're currently doing at neighborhood level to address the fact that neighborhood health is so variable. In our district public health offices, which Neil in his very kind introduction described, these have now been around for 10 years. Also efforts that have been recently bolstered by the City Council and the administration to address gun violence. And then, most importantly, the reason that I didn't agree to come sort of 1 week into my tenure as commissioner, I'm pleased to begin to talk with you about some of the new initiatives that we have underway, focusing on East Harlem. And I know that this is a community with which many of you are already deeply engaged, and I look forward to learning more about the work that you're doing. So these are just underway. I can't tell you impact, but I can tell you what we're planning. This is a very familiar slide to all of you. The impact of variations in health is reflected in the ultimate variation in life expectancy by neighborhood. If we look at the range of life expectancies by health district across the city, the lowest life expectancy is in Brownsville, where it is 11 years shorter than the neighborhood that has the highest life expectancy, which is Murray Hill. So we see enormous variations in life expectancy by neighborhood, and all of the neighborhoods with the lowest life expectancies are familiar to us: the South Bronx, East and Central Harlem, where we are as I speak, and Central Brooklyn. There's also this very disadvantaged strip in the Rockaways. When we look at what underlies these differences in health expectancy, we can see that across a whole range of conditions, which are totally variable in terms of their causal pathway. Diabetes has nothing to do with AIDS in terms of its underlying mechanisms. Asthma hospitalizations, substance use, even the prime indicator of public health, the infant mortality rate, we see that the same neighborhoods light up on these maps. Basically, if it's a darker color, it's a worse outcome. And these variations in outcome occur across the life course. What they mean in terms of the experience of the community is that around every individual are more people with illness. So it says something about the concentration of illness in communities, the concentration of illness across the life course, and of course the variation, and it says something about the fact that these origins of this is structural in nature and not simply a reflection of bad choices by individuals. So you can't have a whole neighborhood where people make bad choices about their sexual behavior, about their eating and risk of diabetes. Obviously, something bigger is going on, something that characterizes neighborhoods as a population, which is more than the sum of the individual risk profiles of individuals. And that's another reason that it's so important to talk about neighborhoods. And of course, the variations that we've seen, the root causes of these inequities, are rooted in the social conditions that vary across the city. Much of this is driven by poverty. But when we talk about what it means to live in a poor neighborhood, it means more than simply being deprived of income. It means having terrible housing stock, unsavory streetscapes where it's unpleasant to go outside, lack of retail opportunities. This photograph is intended to display that the whole panoply of conditions that accompany poverty are what characterize neighborhoods. Of course, neighborhoods also have assets as well as problems. But in the neighborhoods of our city that are the sickest, these are communities that are historically have labored under the burden of discrimination and exclusion. So a key point with which I know all of you agree is that the origins of poor health in these communities is social in origin and not biological. The alignment of poverty and race in this neighborhood, in this city, is indisputable. At the health department, when I joined as commissioner, there was actually very little conversation occurring about race, an issue which really has characterized our nation as a whole. But when we take a look at the difference, if we use race as a way of characterizing the presence of Black and Latino population versus the presence of low-income individuals, they're virtually co-aligned. Only one of these little boxes changes when we use a race lens in New York City or whether we use an income lens in New York City. So in New York City, what it means to be poor is practically synonymous with what it means to be Black or Latino and raises all the issues of racism and discrimination on the basis of national origin as well as poverty. But in spite of that, or another important point to remember is that the leading causes of death are the same. And these are, in this slide pictured here, are leading causes of premature death. This would be before the age of 75. I actually prefer the measure before the age of 65 when it's about the same. HIV comes up a little higher. But what you can see here is whether you're Black or white or Latino or Asian, if you die prematurely, you're dying of the same causes, cancer and heart disease. Obviously, for the population as a whole, these flip. And that's important to remember. Very often people think that the poor die of sort of an exotic set of diseases. But it's the same things that kill all of us, kill all people across populations. And these same causes of disease, so that's a really important point. So it's that these conditions occur at younger ages, with higher frequency and with poorer outcomes, that we see excess mortality by race and income. And similarly, we can see that looking at the non-district public health office areas. So we've told you that the district public health offices are in Harlem, the Bronx, and in Brooklyn. that the same causes of death, although they occur at different rates, the brighter the color, the higher the rate here, the same causes of death vary by neighborhood as well as by race. So that's why we can use neighborhood as a lens to focus on disadvantage. One of the questions that I asked myself and the team when I rejoined the health department is, are we focusing on the right neighborhoods here in Harlem, the Bronx, and Brooklyn? There are other poor neighborhoods in New York City. And the answer is yes. We compared the DPHO areas in Harlem, the Bronx, and Brooklyn, and the levels of excess mortality remain the highest in our district public health offices, even as compared to other poor areas in the city. So the data suggests that these are the communities where we should focus our efforts. I mean, I think that the leading causes of death also raise other interesting things. I mean, when you ask people why are poor people or people of color or people in Harlem, the Bronx, and Brooklyn more likely to die young, I think that people will generally say it's HIV, drug-related, and violence, forgetting the fact that cancer and heart disease lead the causes of death for everyone. And of course, it's important to notice that various forms of violence, suicide, homicide, are important, and that diabetes is high as well. So these are very common causes of disease. What we learn in the poor neighborhoods really will have relevance for the whole city. Our ability to tackle the leading causes of death for the poor and people of color is relevant to our ability to tackle the leading causes of death for everyone. So all of us are very good at describing the problem. This is a familiar set of issues. These neighborhoods have been disadvantaged for decades. And the challenge, of course, always is to figure out how we can address the problems and bend the curve, reverse the trends of high excess mortality rates. So the strategy that is gaining increased currency, not just within the health department, but across numbers of city agencies, is the notion that we develop a place-based approach where we use the neighborhood as a unit of intervention, an idea that was really underlay this founding of the district public health offices a decade ago, and that the overarching goal is that every neighborhood be a healthy neighborhood, that neighborhoods have problems as well as assets, that communities bring to the effort to improve the health and well-being of communities, an understanding of the issues that they face. I think that this represents a key addition, I might say, to the very robust efforts that we took from a policy perspective in the Bloomberg administration to use tools of government like taxation, legislation, regulation, to change the types of unhealthy choices that are foisted on communities by the marketing of unhealthy but legal products. But now, in addition to this, there's a clear acknowledgement that communities have to be engaged and won to the goals that we face, that we adopt as a city government, and that we need to align with communities to help build healthy neighborhoods. So that is not a new idea. I was very pleased to see that in reading about the history of the health department, that LaGuardia, who our current mayor views as really sort of an icon, his desk and his office is LaGuardia's desk, established across the city district health offices. you all may know that there's one just on 115th Street between Lexington and 3rd. These were largely established in the 1930s, but the whole effort to focus on health districts began after the Second World War. And a number of demonstration projects showed how academia, community organizations, voluntary organizations could come together and focus. One of the first district office was actually in East Harlem. There was another one in Midtown Manhattan, another one on the Lower East Side. That became really sort of central organizing foci for these communities in improving the standards of community health. And because of the success of these demonstration projects, LaGuardia established district health offices all over the city, including the pioneer one here in East Harlem. And it was really mindful of this that the district public health offices were established during the Bloomberg administration in 2003. Within the health department, there's been for years sort of a tension between decentralization and centralization. The district health movement in New York City, which had its heyday sort of running up into the 1950s under a very powerful woman, Commissioner Leona Baumgartner. She led the charge on a decentralized approach to public health in the city. For the last 50 years, the department re-centralized. By taking the district public health office approach, we've sought to really kind of bypass the argument about whether we should be fully decentralized or fully centralized by saying that there are only a handful of neighborhoods in this city which really have the serious excess burden of disease, and that we should focus on those, that these become the target of our more intensive and more expensive efforts, and not every neighborhood needs to have this kind of investment, so that the district level approach is more limited in scope than it was in the 1950s. But the goal of the district public health office, which I've been in the process of bolstering, these were very small offices. Those of you who work with them will know that fabulous leadership. They started with a staff of 7 people to tackle the needs of a whole community. This has increased to maybe 20 to 30 people. That's still a pretty small group. In our HIV bureau, for example, we have 200 people. Still a pretty small group of people tackling the needs of entire communities. And so they, in order to meet this mission of focusing on the South Bronx, East and Central Harlem, and North and Central Brooklyn, we've been bolstering the staffing levels, but retaining the lens that the neighborhood is the unit of intervention, that we want to focus on both access to health care and ensuring that we have a healthy neighborhood in which the residents will find it simpler to make healthy choices. This is a recent analysis that we've done looking at the number of avertable deaths. And it also shows the same thing that I've said when we looked at excess mortality in the district public health offices. So you saw this here in this graph. The darker areas are the poor areas of the city, and the wider the circle, the circumference of the circle, the more avertable deaths there are. The notion of avertable deaths is based on the life expectancy of the richest neighborhoods in the city. So if we look at if we applied that experience to the poorest neighborhoods in the city, how many deaths each year would not occur? Now, I want to make it clear that being wealthy is not only a matter of having higher income. The neighborhood that you saw, pictured as a deprived neighborhood with the broken out windows, the boarded up shelves, the barricaded sidewalk, garbage on the street, that doesn't happen in a wealthy neighborhood, not because they pay for it directly, but because they have, the wealthy residents of this city have more resources, both politically and financially, to ensure the well-being of their neighborhood. They have the ability to keep fast food chains out of their neighborhoods by working with their community boards on zoning regulations. So I don't want you to think about wealth as simply a matter of income. We couldn't just pour money into these poorest neighborhoods and avert all these deaths. But still, it's instructive to see what would happen if we talked about the poorest neighborhoods in this city having the life expectancy experience of the wealthiest. And if that happened, up to half of deaths that occur every year wouldn't happen. That's a big number. And you can see that the district public health office areas, here we are with this leading medical center right here in East Harlem, between 40 and 54% of deaths that occur in this neighborhood, based on our most recent data, wouldn't occur if the experience of this community were that of the richest. So there are also other interesting things that come up in this slide. I'm sure you'll notice, and I think I will make them available. But you can see that there are areas that are. This is where I live, actually, in Washington Heights, Inwood. This is a pretty poor neighborhood, but not many avertable deaths. So you also see neighborhoods where pretty poor, not many avertable deaths. These tend to be immigrant neighborhoods. So in any case, this graph shows again that the district public health office areas are important areas on which to focus. Oh dear, I'm just looking at the time. As usual, I'm going to fly through what we're going to be doing. So here they are, the district public health areas, and you can identify them by zip codes or by community districts. And these are the activities that have been underway in the district public health offices. The Bronx office focused in particular on sexual and reproductive health among teens, because the Bronx had one of the highest teen pregnancy rates in the country and in the city. The Brooklyn office has focused on maternal and child health. They had a robust home visiting program, more recently adopt a program of training community members to be doulas and assist with deliveries. And the Harlem office has had a focus on asthma. Across all of the district offices, there's been a very strong focus on food and fitness, on promoting accessibility to healthy foods in communities at a number of levels. So this means not just imploring people to eat fruits and vegetables, but providing health bucks that allow people to go to farmers markets and incentivize the purchase of foods in farmers markets by giving people $2 extra for every $5 that they spend in a farmer's market. By working on improving the retail environment, an effort that's been really pioneered in the Bronx, by working with shop owners to try and shift the way they display their foods in the shop so that healthier items are in the line of sight or at the point of sale, appear at the end of aisles. And this has been an effort to work with business people to win them over to the idea that they can support the health of their neighborhood by reconfiguring their shops and abandoning the planogram that Coca-Cola gives them, for example, which would, in fact, they often would come in and rearrange the shelves. So this actually was very successful, and 88% of the businesses did as well or better financially than they did before. And of course, we don't know what, we can't attribute the ones that didn't do as well only to the rearrangements of the food displays, and they actually sold more healthy products and changed the default, for example, on their deli counters. And so they have done work jointly across the communities, as well as focusing on particular conditions. The Harlem District Office, with support of the now controller and then Manhattan Borough President, established the East Harlem Asthma Center of Excellence, which focused on the problem of asthma hospitalizations in East Harlem. And in fact, the Bronx, which had a very high rate of asthma as well, has not seen the same decline. There's been a 42% decline in asthma hospitalizations. Maybe Mount Sinai can take some responsibility for that too. As compared to the Bronx, an area which also had very high rates. So there were multiple approaches to this. One, better clinical management. Two, environmental strategies and working to reduce the exposure to allergens in the household by a strategy that we call integrated pest management, linking up with healthcare providers, helping individuals better self-manage. So this has been an example of how the district offices link up with the clinical care providers. And here you see the sort of time trend. This is where they started out at a baseline for families that come and get support services. Hospitalizations went down, ED visits went down, and the use of prednisone all went down. So we know that a community-based approach can improve asthma outcomes. Another area where there's been a great deal of effort in recent years, this began after I left the health department in 2009, is focusing on gun violence. Gun violence is declining in New York City in aggregate, but we still have neighborhoods that have very high and unacceptable levels of gun violence, and you'll notice that they are the same neighborhoods about which we've been talking this morning. Now, there are many approaches to gun violence, but the department has adopted a strategy that was initially developed in Chicago called Cure Violence, which takes what's described as a public health approach to violence, and it basically views violence that occurs in neighborhoods as almost sort of an infectious disease. And if you can break the cycle of violence, you can reduce the impact of gun violence on these neighborhoods. It's a community organizing model, one that draws on the use of credible messengers who are often former gang members, people who've spent time incarcerated for gang-related offenses. They get to know, focusing on young men in these neighborhoods, get to know the community, hear about brewing confrontations, appear in hospitals when there's a hospitalization for a gunshot, and try and nip in the bud the cycle of retaliation that often drives gun violence deaths in the community. And this has been a successful, we're just getting started with it here in New York City. Crown Heights, which is the oldest site. It's been there for 3 years. The other sites have been started just in the last year or two. This is not a fast program. It takes time to identify the credible messengers, to build the relationships within the community. So it's too soon to say what the impact of the program has been, but I visited some of these sites. I visited the SOS site in the South Bronx, and they have up on their wall the number of days that they've had without a shooting, and it was 42 days when I visited about 2 weeks ago. So we're very hopeful about this strategy. It's being greatly expanded to 10 neighborhoods within our district public health areas. The total city investment in this is going to be something like $16 million. Here are some of the success stories of the Cure Violence program. But of course, we know that the district public health offices, despite the fact that over the time that they've been in existence, the gap has narrowed, that there's still an unacceptable gap, and we need to continue to focus on it. And I'm going to take the last couple of minutes, and my intention is to reserve some time for questions, to talk about some of the new initiatives that we are getting underway. And these all are under the heading of the East Harlem Demonstration Project. We are focusing on NYCHA housing because our data show that these developments really concentrate disadvantage. Despite the fact that we all know that East Harlem is gentrifying, I would argue to you that the city housing developments really represented, so far, a gentrification-proof setting where enormous disadvantage is concentrated. There are some NYCHA developments that have their own zip code that allowed us to look at mortality in NYCHA-only zip codes. And when we look at them, the mortality rates in some of these areas are actually increasing for some conditions, like diabetes. So unlike the rest of the city, where there's been a progressive advance in life expectancy over the past decade, these are developments that really concentrate disadvantage. So we are using them as a focal point for a place-based approach and focusing on 3 key conditions: asthma, diabetes, and hypertension. The strategy will rely on community health workers, and these are, it's a sort of 3-tiered strategy, one in which we're working with the CUNY School of Public Health and NYU for the evaluation component, with 2 community-based organizations, City Health Works, which I think may have something to do with Mount Sinai, I'm not sure, and the Northern Manhattan Perinatal Partnership to provide the community health workers. The idea is to ensure first that everybody has health insurance, that they are re-enrolled if they've been disenrolled, that they use their health insurance. So that's a development-wide strategy. And further, to identify people with chronic diseases and to ensure that they're in care, that they remain in care, and that they adhere to their care using a health coach model. This is a very biomedical model, and we're also looking to envelop it with more investment in neighborhood improvements, a continued focus on food, access to physical activity, as well as building economic opportunities. The community health workers will be recruited from among residents, if possible. The job description doesn't even require a high school degree. And we're also interested in using arts as a tool of public health. This is the basic idea of a neighborhood approach draws on the concept of collective impact, a concept that's gaining credence across the nation, which acknowledges the fact that most poor neighborhoods have many actors within them that are seeking to improve the health of that neighborhood. But these activities are very infrequently aligned, that people are responsive to their funding source and often may not even be aware of what other people in the neighborhood are doing. So that achieving a collective impact approach means working with the many organizations that are seeking to improve health to identify a common agenda which is held together by shared measurement, that the activities are aligned with the agenda and the measurement indicators that are identified to track progress, that a sort of iterative process of convening takes place in which people work together on tracking their progress towards the common goals and holding each other to account for the undertakings that they've made to contribute to accomplishing these goals. And doing this obviously requires a backbone organization, someone who's a credible convener, a neutral actor, and it will be interesting for us to see what role government can play as a backbone organization. Certainly, we can serve as a backbone organization for ourselves, and the bringing together of multiple agencies within East Harlem, say parks, the Child Welfare Agency, NYCHA developments, housing. The East Harlem is going to be probably the second stop for the affordable housing initiative, which will begin in East New York. And so we are beginning the process of bringing together sister agencies to say what we can do in East Harlem to better align our activities. The number of activities that are underway is really striking. What the Parks is doing, for example, what HPD is doing. And a particular asset that the Health Department brings to this process is our ability to manage data and to collect surveillance data. This is where we are at a start. We are continuing to focus on East and Central Harlem, Central and North Brooklyn, the South Bronx. A key effort in focusing on disparities is a values-based approach to policymaking, arguing that these disparities are both unfair and avoidable, that we can work with communities to improve their well-being without solving the problem of poverty. That a neighborhood can be a healthier neighborhood even if it's a poor neighborhood. And we are committed to a place-based approach that will bring together and bring to bear on these communities the full effort of city government in making people's lives better and healthier. So I think I have about 10 minutes for questions, and I would be happy to entertain them.
We have 2 microphones in the back, and for the benefit of people who are listening and participating remotely, please raise your hand and wait till the microphone comes to ask your question. And we have, you want to? So, we have one question remotely. We'll start with that.
So this question is coming from one of our remote viewers. Her name is Tazy Khan. She's a community healthy food advocate at the New Settlement Apartments in the South Bronx.
I can, oh, okay. It's.
Hello, testing? Okay. I wonder about the impact of mixed income housing on health status of the lower income residents who will be moving into higher income neighborhoods. Since housing is a priority of the de Blasio administration, will the public impact be measured?
This is a question of mixed income housing, which takes people into wealthy neighborhoods. Well, that's, the answer to that is that I'm not sure. I think that we all agree that integration is a good thing, and that it has been underused in New York City as a policy strategy or a public health strategy. Integration across income lines as well as race and ethnic lines. But the units, there are going to be 200,000 new units over many years. Our ability to survey the health of the individual residents in those units is not very high. We just don't. Our community survey, which we do annually based on telephone surveys, has about 8,000 respondents. So we just really wouldn't be able to say whether the health of, the individuals in a mixed income housing development improved or not by being there. It would be a good thing for a research study.
Thank you for that really wonderful talk. My name is Dimitri. I'm a resident at the Harlem Family Health Center. And my question is regarding your effort to engage the support of other agencies in achieving your goals. What challenges have you found in working with these other agencies, and which have been more willing to collaborate and which ones have been less so?
Well, the first thing that I'll say is that, as I began, the priorities of the mayor were to launch pre-K and to launch a massive increase in affordable housing. For both of those initiatives, the engagement of multiple agencies was really incredible. You see the fire commissioner standing up and saying, we're committed to early childhood development. And the number of agencies that were required to, in a period of 8 months, expand by 30,000 the number of seats was phenomenal. It was buildings, it was fire, it was the health department's role was mainly inspectional, the Department of Education, the Child Welfare Agency for Children's Services. So all to get to your question is that the ability for agencies to work together is really greatly facilitated by mayoral priorities. At the same time, there is a growing interest and recognition across, many of these are new commissioners, across commissioners, that neighborhoods are really the unit that we have to talk about. So that the Health and Human Services agencies have agreed to focus on East New York and East Harlem. There's an effort going on in Brownsville. I was at a meeting there where 8 commissioners showed up in a community-based organization's office to talk about our activities in Brownsville. We're just getting started in East Harlem, but I think that the potential for alignment has never been better, but it's not based on any structural factor. It's based on a set of shared values among the agencies. So that's the challenge you asked about. That we don't really have a way to. We're vertically organized, and we don't really have an East Harlem authority, for example, to which all of us report, or a Brooklyn, Central Brooklyn authority. So it's based on our commitment and goodwill.
Can you talk about how you're engaging, like the parks departments, recreation facilities, particularly in places like South Bronx and some places in Harlem where they have few outlets when we talk about exercise and health, particularly as we get into winter months? How are we engaging parks departments, recreation centers?
Yeah. So the district offices have been working with parks for a long time, and there are some real great success stories. For example, at the beginning, we paid for a program called Shape Up, which is a family exercise program in parks, which community members are trained to be exercise leaders. And now the Parks Department picked it up, and they're funding it. So that's a role that we see in the Health Department, to try and get something started, and then hope that the agency will take it up. The Parks Department has been engaged in a really interesting effort to identify underinvested parks across the city. They've made a list of all the places that have gotten less than $250,000 in capital expenditure and in the past decade, and prioritized them. Our role as a health agency is to work with them to promote health and increase access to their facilities, promote programming that, and you know, I think that they're doing a really good job. The rec centers are the main source of indoor exercise, and many of them need capital improvement. But $25 million has been identified in this coming fiscal year, and the expectation is that it will be renewed for a period of 4 years. So our role really is working with them on sharing our expertise on evidence-based approaches to promoting exercise. But in order for the parks to be more available to members, they need more investment, and they are now beginning to get it. Does that answer your question, or not really?
Thank you for the great talk. I know that you mentioned for the East Harlem demonstration project, there's sort of a health coach approach, recruiting people from the communities. I'm curious to know, for the 3 communities that are being focused on, how are, I guess, agents who would coordinate the health care of folks in the community being engaged?
That's a very good question. Yeah. So first, let me make clear that this community health worker initiative is focusing on 5 housing developments in East Harlem. The number of residents in these developments is about 12,000, and it is a place-based approach. We don't know where people are getting their health care. We have some ideas because A1Cs are reportable to the health department, and we have a program called the Primary Care Information Project, which gathers information about small and group practices in Harlem. So we think that at a minimum, people have 30 sites of health care if we look at the patients with diabetes. So that is obviously the challenge, to build links with the primary care providers. We all know that community-based workers are only successful when they have a strong link with the provider. One of the groups that we're working with, City Health Works, has a track record of building those links, and that's going to be the challenge of this project. We're confident that they can find people who will want to have coaching, but making the link with the provider is absolutely going to be the challenge. The other way to do it is to start with the provider and reach back out to the community, but then you lose all of the assets of a community-based approach. You can't have things like floor captains, building leaders, activities that are aimed at promoting healthy food and exercise within the development that allow a collective approach to promoting good health. You're just looking for one patient at a time wherever they live when you start from a practice and go out into the community, unless that practice has its client base very strongly from one place. So
I
think that's it.
Associate, then
Yes.
you have to leave.
Yeah.
So I just want to thank Dr. Bassett and leave you with 2 thoughts. So one is that we have been pushing hard to make the case that primary care folks are public health folks, yes, and that the 2 systems that have been separated by disciplines for a long time really do need to come together, and I think your talk really drove that home. And also to tell you that I'm very proud that all of our residents in family medicine actually adopt a community agency during the beginning of their residency, and they work with them through the course of their residency program. So we're seeding people out in the community, and I was very struck by some of the things you said about how we're trying to organize some of those agencies, you know, so that we don't have 1,000 points of light, but maybe 100 coordinated points of light. So thank you very much for coming. We look forward to working with you.